Well, value-based systems, the ones that many of the insurers are using now, really looks at very different parameters than the traditional reimbursement systems. So what they look at is they look at the frequency of checkups, of well visits, because that's really critical. In pediatrics and also in adult medicine, they look at immunization rates. Certainly in pediatrics, we do a lot of that, but even in adult medicine, they're doing more and more regular immunizations for certain disease states. They look at certain screening tests. For instance, in children now, it's recommended that even as young as 10, 11, 12, that routine lipid screening be done to pick up kids who might have either genetically based or physiologically based hyperlipidemia. There's a new requirement now to do chlamydia screening, urine screening on all sexually active young women, and we would like certainly to enlarge that to all sexually active teens. So on the preventative side, that's one of the quality-based requirements they're looking at. On the chronic care side, on the chronic illness, or rather on the illness side, what they're looking at, let's talk about acute care and then chronic care. On the acute side, simple things that they look at is if you make a diagnosis of a pharyngitis, of sore throat, did you do a throat culture? Because their concern is people getting antibiotics unnecessarily when they don't have a bacterial infection like strep that would require an antibiotic. They would look at a diagnosis of upper respiratory infection and look to see whether antibiotics were prescribed, because for simple URI, simple colds, obviously you shouldn't be prescribing antibiotics. So that they would look at certain parameters on acute diseases. And then on chronic diseases, that's a whole nother area that they look at quality. And there what they would be doing is, number one, making sure that the practice with certain disease states was following evidence-based guidelines. And so one of the things that we've set up is certain protocols for handling certain chronic diseases. In pediatrics, the big chronic disease that we deal with is asthma. In adult medicine, obviously, we have type 2 diabetes and heart disease and high blood pressure, et cetera. But for us, our big chronic disease area was asthma. So we've set up protocols. We've set up systems where we can see how often the patient's refilling medication. Are they coming in for follow-up visits appropriately? We're setting up disease registries, and this is really critical, where we have a list of all of our kids that have asthma to make sure that proactively we can follow are they coming in as they should be? Are they overfilling their medications, et cetera? Are they getting certain tests they need to have done on a regular basis, such as spirometry? We also do what we call an asthma control test, which is a questionnaire that we do at each visit. So those kinds of things that we're monitoring. And then the other piece that they are looking at is the quality of care management and also care coordination. So are you managing these chronic diseases appropriately? And are you coordinating the patients with, now coordination means outside of your practice, with other specialists, with coordinating it with perhaps visiting nurse programs, things of that nature. And as well as tracking the referrals, tracking that they're going for their lab tests. And then the other area we get into is costs, which are obviously critical on both sides. And some of the examples of that our payers are looking at is, for instance, generic prescription rates. You know, how often you're prescribing generics. They want to be you to be able to. They want to look at your emergency room use. You know, how frequently are the patients going to the ER, and obviously we try to keep that down. And then they're also looking at hospital admission rates, especially for ambulatory-based diseases. You know, so if you have a heart attack, that's one thing. But for instance, for us, using again asthma as our example, you know, how often are asthmatic children going into the hospital? Can those admissions be prevented?